As you know, that foot and ankle trauma is now have now become quite common as well. Why? Because usually the most commonly always are the motor vehicle accidents, and the problem is the dashboard injuries. Either they affect your knee, or especially on when the foot is on accelerator, or when the car is actually stuck in such a way that your foot, mainly the part of the body which is gets caught in the trauma, is always all those structures which are below knee and below knee. Usually they're associated with leg fractures, ankle fractures, foot fractures, and there is no increased incidence of this foot and ankle as well as the leg fractures. In this lecture, we will be mainly going through the talus fracture, which is the bone which articulates with the tibia, forming the ankle joint, then articulates with the naviculum to form a tero-navicular joint, and which is actually articulating with the tarsal bones, and then it also articulates with the calcaneum, forming a subtalar joint. Now, if you see it just by mentioning the name of the bones, it's a very important structure which is actually there is no tenderness or bone insertion on it. As a result, what happens is it's actually kind of a main center where it's with the mainly the midfoot, the hind foot, as well as the tibia is articulating. So it's kind of a communication between different parts of the bones. Therefore, it has a very important role in the biomechanics of the ankle. We'll be first discussing how to do the clinical assessment. Clinical assessment always starts with the brief history. Whenever a patient comes to you with the trauma, there is always the first and foremost is ATLS guidelines. The foremost important is always that simple, that airway and cervical spine. Then you come to the breathing, circulation, and then disability. If all these structures are okay, the patient is vitally stable, there is no life-threatening lung injury, there is no life-threatening abdominal injury, life-threatening head injury, then when once all that is okay, patient is temperature is okay, patient is exposed, and there's no other injury, the only problem is actually the isolated talus fracture, then you move on to the assessment of the talus fracture. And how do you move on to it? First, you can take the brief history. What happened to the patient? Most likely, there will be a history of some form of a fracture, either fall or there will be motor vehicle accidents. If there was a fall or motor vehicle accidents, you elaborate more on what was the position of the foot when the patient had that kind of an injury. Usually, it's not possible, but sometimes patients are aware of it. Then, when they had that kind of an RTA or a crash, their foot was on the braking pedal, their foot was on the there was on the accelerator or not. When you're pushing the accelerator, your foot is actually going into the plantar flexion. But when you're applying brakes to the car, this is a general tendency, because when you're applying brakes, your foot is actually in some form of a dorsiflexion. So if the patient is able to give you enough history that he or she was applying brakes and the car had a head-on collision to either wall or to side settings, or this hit another car when he or she was applying brakes, you can automatically sense that actually the position of the foot during the trauma was in some form of a dorsiflexion. Now, if what happened is that if force was so much that despite having an RTA, the patient was launched forward, or patient was going actually forward into it, then this means there may be foot was in dorsiflexion, but there was some form of axial loading of the tibia which is actually occurring on the ankle as well. So there is definitely some amount of axial loading with dorsiflexion. Immediately this could be you should raise suspicion that this patient may have either talus fracture. This could also be, if this is the condition of the foot, you see this swollen foot, more so on some form of superficial wound over here, a lot of ecchymosis, there is loss of medial arch as well. Definitely no, if you see this kind of a foot, the first and foremost is most likely the problem is either the forefoot or the midfoot, because this is where the most swelling is. But if it's talus, the swelling would mostly towards the ankle, and you could appreciate that the medial malleus lateral malleus would be blurred. There is a lot of swelling around the ankle which would be present as well, and you can appreciate something is wrong over there as well. So then comes the examination. Examination starts with the actually eliciting where the tenderness is. If the forefoot is damaged, then there would be tenderness over the metatarsals or tarsal bones. But in case of talus fracture, the most tenderness would be over the ankle joint. And when you palpate the medial joint, medial malleus or lateral malleus, there will be definitely amount of tenderness which would be present in the ankle area. Now, if once you have assessed the patient as per you manage the patient per ATLS guidelines, and you know there's an isolated foot injury or foot and ankle injury, then whether it's talus, whether it's some other bone like calcaneum, it could be cuboid, it could be simply distal tibial fractures as well, because around the ankle these all bones could be involved. So how do you assess it? You assess it by getting an X-ray. What X-ray we need to get is simple, that we need to get AP and lateral series of the ankle, APV of the foot as well. Now this is an APV of the foot showing that probably the forefoot and midfoot is intact. You can appreciate over here, this is the cuboid. These are three cuneiforms, and talonavicular joint and naviculum appears okay. At least on the forefoot and midfoot looks okay, but you can get AP and lateral view of the foot as well as the ankle. Now this is the lateral view of the ankle as well as the foot. You can appreciate the subtalar joint, talonavicular joint as well as the tibiotalar joint, and this is what you need to look at, as especially in the case of the talus as well. If there would be fracture, there would be present over here in the neck area or in the body, and you need to look at the subtalar joint and our tarsal canal as well. You can appreciate the tarsal canal is very much intact. Now if you see, this is probably a CT of another patient. Sometimes you have to get AP and lateral views. Sometimes special views are also required as well. If you're suspecting calcaneum fracture, you may have to get Harris views, which is special kind of views. But in case of talus, there is special views called as canale views, which may be required as well. Now it's sometimes very difficult to get a canale view. You have to explain to the radiographer that how to get that canale view. The foot is actually foot is plantigrade on the ground, with the film is underneath the foot with 15 degree of inversion, and the beam is actually coming at 75 degrees of angulation. It's kind of sometimes very tricky to get in canale view, and sometimes the beam may not be at that angle, the patient may not be inverting the foot properly. So the best option is to get a CT scan. Once you get a CT scan with a 3D reconstruction, that's very easy, that you can easily view what are the different joints are actually. If you see this CT, you can appreciate the talonavicular joint is okay, naviculum is okay, with the subtalar joint is very much intact, and as well as that tarsal canal. Tibiotalar joint is okay. You have a suspicion there is some fracture of the talar neck, probably is undisplaced. So probably this is Hawkins type 1 fracture. So then you can also get an MRI as well, although it's rarely indicated. But sometimes, to have a better view of the soft tissue damage, to have a better view of how much the ligaments are torn as well, and if there is no bony fracture, there may be associated only ligamentous injury. To view that, you have to go for an MRI. Then comes the treatment. Now treatment, one thing, there is a definite treatment and then there is an initial treatment. For all the foot and ankles injuries, whether they involving talus, calcaneum, cuboid, naviculum bone, distal tibia, the initial treatment for all the foot and ankle injury is same, and that is actually to realign it and splint the foot. You just put the foot in the plantigrade position, apply a back slab or splint it, so that patient becomes pain free. Then to make it prevent excessive swelling, and eventually excessive swelling can lead to compartment syndrome, which could be disastrous for the patient, just keep it elevated. And further, to prevent swelling, either apply cryocuffs or ice packs. Usually ice packs are good enough, and then you have already splinted because the crepe is already applied on the foot as well. You can just apply the ice packs. Why? Because elevation and ice packs will prevent further swelling. If there is a fracture or even the ligamentous injury, there will be definitely swelling, and excessive swelling can eventually lead to compartment syndrome, and compartment syndrome can be disastrous because later on there will be clawing. There could be problematic with the foot because patient may not be able to walk properly later on. So what you need to do is you need to make it sure whether the fracture is present or it's not present. What you need to do is you need to prevent swelling initially. Then intermittent pneumatic compression and foot pumps can be used. Why intermittent? Because continuous compression can actually disrupt the vascular supply. So when you are trying to prevent compartment syndrome, this continuous pressure would actually create one. So what you need to do is do intermittent pneumatic compression so that the swelling does not happen. And then once you have the history, you have the examination, how much instability at subtalar or tibial joint is there or not, or whether there's tenderness at the medial lateral malleus, if there are tenderness tarsal bones, or if there tenderness forefoot. This with x-rays you can make a diagnosis whether what is the injury to the, whether it's the forefoot, it's the midfoot, it's the talus, it's the ankle, or it's the tibia. Depending upon where the injury is and where the tenderness is, you can make a diagnosis. And once you have made the diagnosis, then you can decide upon the what classification to apply on it, and whether to go for conservative treatment or to go for definitive treatment. And then whether if you decide to go for definitive treatment, you start the definitive treatment. Now in talus, there's a different, if you see this is the talus bone in a 3D. Talus has a different anatomical structures. As I told you, that there is no tendon or actually muscular attachment to the talus. Only the flexor hallucis longus is actually just going below the posterior articular process, but is actually not attached over here. It just passes below it. There is no tendinous insertion or muscular attachment to the talus bone. This is called the dome or the body of the talus. This is called as the talus neck, and this is actually which connects the anterior part to the posterior part. This is the head of the talus, which articulates with the naviculum, forming a talonavicular joint. Then this head is on the inferior aspect is articulating with the sustentaculum tali of the calcaneum. So actually head articulates with the naviculum as well as sustentaculum tali of the calcaneum both. Then is a lateral process. Now this lateral process has just hinges it over of the calcaneum. There is no articulation with any other bone. Then this is an articular surface of the posterior process. This is anterior, this is posterior process, this is a body, and there is a neck in it. This articular surface articulates with the calcaneum, which is forming the posterior process. Now, before going on to the mechanism of injury, I would just like to briefly tell you about the blood supply. Why we are worried about the talar neck fracture is that blood supply is such that this area is actually that is called as artery to the tarsal canal. Now this is the talus. Now there is a calcaneum in between, and there is a space in between the calcaneum talus called as the tarsal canal. The blood supply is coming to this through the posterior tibial artery. Posterior tibial artery gives off an artery branch called as artery to the tarsal canal, which enters into the tarsal canal and supplies major blood supply to the body as well as the neck and the anterior process. Now if the neck gets fractured, the anterior process is almost all getting the supply from the artery to the tarsal canal, and if this gets fractured, this whole area becomes avascular. Other parts of the body like posterior process, lateral process, they may be getting perforating arteries as well from the peroneal artery. There may be small amount of supply to the anterior process through the anterior tibial talar artery as well as some as well perforating branches, or from the medial side they may be arising and sending upwards through the branches of the deltoid artery as well. But this anterior tibial, deltoid, peroneal artery perforators, these are actually a very small part is actually supplied by these arteries. The majority of the blood supply is actually coming from the artery to the tarsal canal, which is a branch of the posterior tibial artery. So if the tarsal canal is disrupted, there is a chance that there is high chance that probably a patient will have eventually avascular necrosis of the anterior process if the neck gets disrupted. Now what is the mechanism of injury? As I told you, the most common mechanism is always axial loading with dorsiflexion of the foot. And how it happens, the patient will not tell you my foot was in dorsiflexion, but definitely tell you when I was trying to apply brake, when I was applying brakes, this is disaster happened. And when the brakes are being applied, the foot goes into dorsiflexion. and there's axial loading over here as well, and this results in that you can appreciate over here the tibia is coming downward, foot is going upward, the talus is actually crunched in or caught in between. As a result, there is always a chance the neck gets fractured like this. And then whether once the neck has fractured, what else joint has got involved is that this actually forms the classification or basis of the Hawkins classification, because you can appreciate over there is a subtalar joint. If the fracture goes only and fractures it, it's okay, it becomes type 1. But if it involves subtalar, this becomes type 2. From here it's involved as well tibial joint as well, the dome gets disrupted, becomes type 3. And once the fracture is so much that it's involving the talonavicular joint as well, then it becomes type 4 as well. Now coming to the clinical features, if we know it will be specifically talus fractures, what would it present like? The patient will have a swollen foot, especially the swelling would be massive around the ankle joint. Will have an obvious deformity, and obvious deformity in form of the patient would have either dorsiflexly positioned, or patient would have a malformed malleoli and would look like some part of the talus would be actually extruded out of the talonavicular joint. There may be skin may be tented or split, usually may present with an open fracture as well. Skin may have a slough and become infected, because if it's over a long period of time, this may get resulting in a sloughing or infection, but usually in acute cases this is rare. Above all, it will be highly painful and patient will not be able to bear weight. Why it's important it becomes painful? Because all the neurovascular structures also get disrupted. The fracture is highly painful and patient is not able to bear weight at all, because the biomechanics of foot and ankle is actually completely lost. Now coming to the injury classification. The one way of classifying the talus is anatomically. As I told you, it has multiple other structures. For example, whether the neck was fractured, or the neck can be further subdivided into type 1, type 2, type 3 and type 4 actually, which is called as Hawkins classification. Type 1 is when the neck is fractured and it's undisplaced fracture. Type 2 is when the neck has fractured and the subtalar joint is either subluxed or dislocated. When the fracture involves the subtalar joint, it becomes type 2. Type 3 is the force is actually increasing, and that is a result there is increased axial loading over the talus in such a way that the fracture of the neck has occurred. There is involvement of subtalar joint which is subluxed or dislocated, as well as there is other involvement of tibial joint as well, that the dome of the talus is also involved. Now one becomes type 4 means the energy was further massive, there was high axial loading with dorsiflexion of the foot, leading to involvement of all the three joints. That is, there was a neck fracture involving the dislocation, subluxation of subtalar joint, subluxation, dislocation of the tibial joint, as well as the subluxation or dislocation of the talonavicular joint. When this happens, this is called as the Hawkins classification for talar neck fractures. Other way of classifying is actually anatomically, that either you classify as a fractured neck of talus, or it could be simply the head of talus as well. Head of talus involves mainly the anterior process of the which is articulating with the naviculum or the sustentaculum tali, or it may involve the body actually. That is the dome part of the talus. But why it is when it's actually classified differently from the neck? Because it may be involving the body or the dome, but not involving the tibial joint. That is why the fractures body are a different entity when we are classifying as according to the anatomic classification. The other is the fracture of the lateral and the posterior processes. Anatomically, I told you there is a posterior process as well as the lateral process. The lateral process articulates with the sustentaculum tali. The posterior process articulates with nothing, but there is a tendon of flexor hallucis longus which is passing just below it. Therefore, these are actually separate entities and they're shelf-like projections of the talus. Therefore, they can get fractured or avulsion fractures can occur, and they are classified differently from the talar neck fractures. Other could be a rare entity, but yes, it's very common that osteochondral fractures. Mostly the osteochondral fractures involve the knee joint, but the second most commonly they involve the talus, and the third most commonly they involve the capitulum in the elbow. Therefore, after knee, the talus fractures could be this osteochondral fracture of the talus could be the second most common osteochondral fractures in the body. Now coming to the classification. As I told you, this is one way of classifying it, that is the anatomically. You can involve the fracture involving the posterior process. If you see this X-ray, subtalar joint appears intact, tibiotalar joint is intact, but there is a posterior fracture involving the posterior process of the talus. This could be involving the talar neck. Now, talus neck is further subdivided into 4 subtypes. This appears to be the type 2 because there is neck of fracture as well as which is displaced and involving the subluxed subtalar joint. Then it could be the talar head involvement as well. There could be simply oblique fracture like this, or it could be a straight fracture which could be involving the articular surface. But the important point to remember is usually the talonavicular joint is spared. If you can appreciate it over here, talonavicular joint is mostly intact. There is oblique fracture involving the talus anterior process or head of talus. Then the body may also getting involved as well. The body usually when gets fractured, sometimes the tibiotalar joint may be involved as well, or mostly it's spared. In this you can appreciate that there is a fracture of the body along with the involvement of the tibiotalar joint. Now coming to the fractures of the neck. As I told you, there is a Hawkins classification for this, which has further subdivided fractured neck of talus into 4 subtypes. Type 1 was the fractured neck of talus which is undisplaced. If you see it over here, there is a fractured neck of talus extending all the way, but the subtalar joint is intact, tibiotalar joint is intact, talonavicular joint is completely intact. This is type 1, in which is an undisplaced fracture of the talar neck fracture. Now type 2 is when this fractured neck gets displaced and involve the subtalar joint. If you see over here, there is a displaced fractured neck of talus involving probably the whole subtalar joint is dislocated in this case. There may be subluxation or dislocation of the subtalar joint along with the talus neck fracture. Type 3 is when this neck fracture along with subluxed or dislocated subtalar joint may also involve the tibiotalar joint. If you see it over here, there is a neck fracture involving the subtalar joint, as well the fracture line is extending all the way back up to tibiotalar joint. Although in this X-ray probably the talonavicular joint is not visible, but usually the talonavicular joint is always intact in this case. Now type 4 is the fracture is so accumulated, or the axial loading is so high in energy that this results in actually involvement of all the 3 joints. There is a fractured neck which is dislocated, the subtalar, tibiotalar, and even the talonavicular joint as well, which cannot be appreciated in this X-ray. Now coming to the OTS classification. Now there are different ways of classifying talus fracture. Talus neck is classified by Hawkins, but other parts of the talus such as body, such as dome, such as processes lateral and posterior are actually classified in form of OTS classification. Although there are different other classifications for that as well, but we will only discuss the OTS classification over here. Talus fractures can be divided into avulsion of the processes, the head fractures, which could be simply avulsion fracture, could be a process fracture, or could be a head fracture. Then could be the neck fractures. We have already subclassified as per Hawkins into non-displaced, displaced with subluxation of subtalar joint, displaced with subluxation of subtalar or ankle joint, and there may be involvement of talonavicular joint as well. Then comes the body fracture, which involves the ankle joint with the dome fracture, which may involve subtalar joint or which may not involve it as well, and there may be involvement of both the ankle, that is the tibiotalar, as well as the subtalar joint. Now if you see avulsion fractures, there are different X-rays which you can appreciate it over here, that if you see on lateral view, you can only see a chip fracture, which is very small part of avulsioning out of the anterior head of the talus. Now this sometimes could also be an osteochondral lesion, so you need to be very clear whether it's an avulsion or osteochondral lesion as well, as 70% of the talus is mainly covered by the bone. So this is on schematic diagram. It appears to be an avulsion fracture, which is actually taking it out. There could be a process involving elsewhere. In this case, there's a lateral process fracture, but this is usually on AP view. You can appreciate this is the fracture, which is a small part, maybe very subtle injury, and you need to look at very carefully. Now coming, sometimes the whole lateral process may be involved. If you see this is CT, you can appreciate a very large chunk of the lateral process is actually involved. Or this could be involving the posterior process as well. This is an X-ray which is showing a very big chunk of posterior processes being torn out from the talus. Now, if you see other way of classifying these fractures actually in form of whether it's comminuted or it's non-comminuted, whether it's involved with subtalar joint or it's involved with tibiotalar joint. If you see, this is a non-comminuted type fracture, which a single line passes over here, but this is involving the subtalar joint. Other is a comminuted. If you can appreciate over here, there is almost whole of the talus is actually zopped due to the comminution, and this is involving joint as well. Now this could be a non-displaced fracture, which could be like this, which is classified as Hawkins type 1, because you can appreciate this is a neck fracture running all along till the subtalar joint, but the subtalar joint appears to be intact. Or this could be displaced with subluxation of the subtalar joint, which is actually termed as Hawkins type 2. If you see it over here, there is definitely subtalar joint involvement along with the neck fracture. Or it could be comminuted with subtalar joint. That displacement is still, but it's not a single fracture, but it's a highly comminuted fracture. You can see the subluxation of subtalar joint. This is a fracture. There are other small pieces going on, and there are other fracture lines which may be going upwards like this as well. So actually there's a comminuted fracture involving the subtalar joint, or Hawkins type 2 as well. Then it could be a type 3 injury as well. When there is so much combination, these fracture lines can go all the way back into the subtalar joint as well extend into the tibiotalar joint. And sometimes when there is a combination present, you need to look very carefully, is it type 2 or is it Hawkins type 3? Then comes the displaced with subluxation of subtalar and ankle joints. Now if you see this fracture line, there is a fracture neck of femur extending the subtalar joint as well as the ankle joint is involved as well, although the talonavicular joint is very much intact. This may be a comminuted fracture involving both the ankle as well as subtalar joint, as you can appreciate it over here. This is a fracture extending all the way. These are also fracture lines. This is one piece, second, third, fourth, fifth, sixth pieces. You can appreciate a very comminuted fracture, but it's extending into the ankle as well as subtalar joint. And this could involve the talar head as well, because one of the fracture line may be crossing all the way anteriorly into the talus head. Now ankle joint involvement with dome fractures. Sometimes what happens is, if you see it over here, this is the fracture which may appear. Now this kind of a fracture may be an avulsion type fracture. This could be an osteochondral lesion, or this could be a fracture of the dome of the talus. Sometimes on X-ray you're not very much clear about what type of pattern it is. You may need to get a CT as well, and if you get a CT, you can very well appreciate this is actually a more of a comminuted fracture. The fracture of the dome and the multiple small pieces which can be seen as well. Now sometimes there's involvement of subtalar joint only, and this is actually happens when there's a lot of axial load with not a lot of dorsiflexion. So actually all the load of the ankle is going on to the subtalar joint, and subtalar joint may get, there is a non-comminuted fracture, or they may get a comminuted fracture of the subtalar joint along with the involvement of the calcaneum fractures as well. Now sometimes what happens is this ankle and subtalar joint both may be involved. If you see, this is schematic diagram that this energy axial loading over this resulted in a dome fracture and ankle fracture as well as all the way up to the subtalar joint. So both the tibiotalar and subtalar joints are involved, which can be appreciated over here. Or it could be this kind of a situation which there's a comminuted fracture with dislocation of the talus and always the involvement of tibio-talar as well as subtalar joint. Now coming to the treatment. As I told you, the treatment depends upon the classification. If it's type 1, that means it's an undisplaced fracture, neck of femur, neck of talus. That can be simply treated conservatively in form of, you can give short leg cast for 6 to 8 weeks. But if Hawkins type 2, that is the displaced fracture with involvement of subtalar joint, or if there is type 3, that is involvement of subtalar as well as tibio-talar joint, or type 4, that is involvement of all the three, that is subtalar, tibio-talar and talonavicular joints, then you have to go for open induction internal fixation with either the K-wires or cannulated screws. In this, you can appreciate this was the fracture with subtalar as well as tibio-talar joint involvement. Probably this was Hawkins type 3, which has been fixed with headlock screws or 4.5 mm screws, which are actually passed anterior to posterior. K-wires can also be passed in this. It was a type 2 injury, a fracture involving the subtalar joint only. Then that can also be done, but usually K-wire construct is not stable, and then we have to go for casting as well. Therefore, once we have passed the screws, then we can go apply the cast for at least 6 to 8 weeks, and later on, after 6 to 8 weeks, we convert that cast into splint. But with K-wires, you have to keep it in the cast for a longer period of time. So if the displaced fracture of the body is not involving the neck, then you have to look at what are the other associated fractures as well. For example, this was a displaced fracture of the body which was fixed with a screw, as well as there was fracture of the medial malleus, in which this malleus screw was also passed. Now if you can appreciate it in the lateral view, instead of one, there were actually 2 screws for the malleus which were passed, and 1 screw for the talus body was used in open reduction and internal fixation of this talus as well as medial malleus fracture. Now coming to the internal fixation. Internal fixation is actually done by form of open reduction internal fixation with cannulated screws. That is, the first you reduce the talus back to its position, you make it sure all the joints are intact, then you pass the K-wires, then over the car you can pass the cannulated drill which creates space for the screws, and then you can pass the cannulated screws in this fashion. It could be either 2 parallel or it could be 2 crisscrossing, but usually the screws are always going from anterior to posterior. Now moving on to osteochondral fractures. As I told you, sometimes in the body there is avulsion fractures called as avascular necrosis due to non-traumatic causes of avascular necrosis is mostly in the knee as well, and these osteochondral lesions can occur in the talus as well as in the capitulum. In the talus, the second most common cause in the body. They may include very small chip out fractures. If you can appreciate over here, this could be due to subchondral collapse. As this articular surface is covered by the cartilage, there may be avascular necrosis of the bone, the subchondral bone, which is just below the cartilage, and this may lead to collapse. Or it could be this kind of a pattern in which there is a very small chip which may not be appreciated straight away, and you may require other modalities as well to review it. Or it could be this kind of a situation in which there could be a large chunk of fragment which may be involved as well, and which initially may mimic some sort of a dome fracture. You need to get a CT to rule out whether it is a dome fracture or is it just subchondral collapse due to osteochondral lesion of the talus. Now there is a different classification as well depending upon the size and the site involvement as well, but usually different classifications used differently, and there's not a lot of a difference when it comes to the prognostic value for these classifications. So coming to the treatment of these osteochondral fractures. Now osteochondral fractures actually can be treated depending upon the size as well. The patient may be given short leg cast for 6 to 8 weeks and allow it to heal along with analgesics so that these fractures can heal over time, and protected weight bearing can be initiated. Or what we can do is that we can, if there is a small fragment which is actually displaced into the articular joint, we can go for ankle arthroscopy and take that out, and so intra-articular segment is actually lost. Other option is Other option is actually that we can go for open reduction and tunnel fixation of these segments with bone grafting. For example, if this was a large segment, one option is go for retrograde drilling, that you pass a drill to this area and you drill this bone and then you fill these areas of all this area with the bone graft. Or what you can do is you can go for open reduction and tunnel fixation, take this area out, put the bone graft over here, and then fix this bone graft to this area. So that is also an option as well, but there are different options depending upon the size and modalities which are available. It could be simple conservative options such as short leg cast for 6 to 8 weeks with protective weight bearing. It could be an arthroscopic removal of the foreign body or loose bodies which I may have dispersed into the joint, or it could be simply retrograde drilling with bone grafting, or it could be open radiation tunnel fixation with bone grafting as well. Now coming to the complication which may be associated with the talus fractures. As you know, the talus is a very important bone and very important for the biomechanics of walking and foot and ankle. It forms three important joints. With the calcaneum below, it forms the subtalar joint. With the tibia above, it forms the tibiotalar joint, and with the naviculum in front, it forms a talonavicular joint. For talonavicular joint is talus connection to the midfoot. Talocalcaneal joint or subtalar joint is actually connection to the hind foot, and as tibiotalar joint is actually connection to the leg. So it's sort of an interplay in between when all the forces are gonna cross over during the walking and running. The most common is the malunion or the non-union. If you appreciate it over here, the screws are in place. There are not only 2, maybe 3 or 4 screws been passed, but actually the fracture line is in the non-union. Now this could happen. Why? Because the initial injury may be so much that actually the fragment has become sort of avascular, and even if you fix it properly, or if the fixation was not proper enough, this may eventually lead to avascular necrosis, eventually leading to malunion or non-union, and patient will have a lot of problems with walking. Patient may complain of pain in the ankle joint. Patient may not be able to climb up the stairs because of pain, and patient may be having very debilitating problems such as may not be able to carry out daily activities of life, and as a result the patient may be in really agony because of pain which may be occurring with every step he or she takes. The other problem could be the avascular necrosis. As I told you when we were discussing the anatomy of the talus, the major supply is through the branch of the posterior tibial artery, which is the artery to the tarsal canal. And if that gets during the neck fracture gets disrupted, there is maybe very high chance of involvement of in head of the talus may get avascular or necrosed. Now, if you see the Hawkins classification with type 1 injury, there is really 0 to 13% chance of avascular necrosis. If type 2 injury is there, that is neck fracture with subtalar joint, there may be disruption of few vessels, which may be lead to almost 20 to 50% chance of avascular necrosis of the talus. But with type 3, as the energy impacted on the talus increases and the injury severity increases, the avascular chances also increase. With type 3 involving the subtalar as well as tibiotalar joint, this may be 50 to 70% of chance of avascular necrosis. And with type 4 injury, when talonavicular joint is involved as well, there may be as high as 70 to 100% chance of avascular necrosis of the talus. And how we know that, what we need to look for is whenever we have applied short leg cast, we have fixed the talus, what we look for is the Hawkins sign, that is the subchondral sclerotic lines, which is maybe visible in the dome of the talus after 4 to 6 weeks after the fixation or application of short leg cast. Now, if these lines have appeared, that means that revascularization is adequate. But if these lines don't appear, probably the revascularization is not adequate, and eventually this could go into some form of non-union, malunion, and even avascular necrosis. Now coming to the other complication, which could be form of a secondary osteoarthritis. Secondary osteoarthritis can develop especially due to the high energy impact at the time of injury. As the different joints are disrupted, there could be tibiotalar joint disruption, could be subtalar or talonavicular joint. Eventually, this can lead to ankle pain, ankle stiffness, osteoarthritis with the ankle, which may have to be treated eventually with orthodesis or ankle replacements. Because if you see this, all the tibia joint is quite intact, but if you can appreciate the subtalar joint is very much arthritic. There is reduced joint space, there is an osteophyte formation as well, and there may be the patient may have a lot of pain and complications associated with walking as well. Patient may not be able to fully bear, or patient may be agony while walking, and patient may not be able to walk for a longer periods of time. So on this case, this may be due to the injury which have occurred at the time of trauma may be so severe that eventually some form of arthritis does happens later on, and which cannot be prevented. Later on it needs to be treated as per the arthritis protocols. So that's it. That's for this lecture. I hope you have enjoyed the lecture on talus, and probably you have enjoyed and realized that treatment of the talus fracture is highly important. And what's more important is that we need to restore the vascular supply of the talus by going for proper reduction and fixation of the talus fractures. Thank you very much. Keep watching sqadia.com.